Welcome to part 6 of non-intentional childhood injuries. We're going to discuss poisoning, and it funnels into our week 2 content in well child care and anticipatory guidance. And we discussed how our toddlers and our preschools, school-age children, are curious and they get into things, and so they have a higher risk for poisoning injuries. And why is that? When you think about our homes, we have a lot of chemicals that are very harmful if ingested. We keep them under the sink. They're all over your garage, and we have them in bathroom cabinets because it's very convenient to use them. Medications. Where do you store them in your own home? Does your grandma or grandpa keep their medications in a convenient spot for their use? Are they using the child-proof caps? If they have arthritis, they probably aren't. Many people who are on numerous medications are putting them in those containers where they know what to take, actually Monday through Sunday, and what do I take in the morning and what do I take in the afternoon. And these are readily accessible to children. In addition, we can have inhaled poisons from a fire. When there is a big fire and a child inhales, we don't even know what's burning, and it can include chemicals that are in the garage, in the household, etc. So our priority interventions here is we really do have to find out information. Unlike previously when I said, okay, we've got to do a quick assessment. Well, we still are going to do an assessment, but for poisoning, we need to start asking questions quickly. We need to find out, was the child found while ingesting the substance? That's going to give us more time. Plus, we know exactly what the kid took because it was witnessed. What time did it occur? How did the event happen? That doesn't have to be right now because that kind of puts blame on whoever's watching the child. But we want to know, what substance did the child get into? Where were they when it occurred? Has there ever been any other previous episodes? Because if a child does it once, there is a high risk that they will do it a second time. In addition, does this child have any other medical problems, including allergies, that may affect what we need to do with them? Poisoning prevents a physical as well as an emotional crisis for us, for the child, and for the parents. Physical, whatever the child ingested, has the potential to cause profound harm, and so time is of the essence for us to intervene. It's an emotional crisis for them because their parents are panicking. They're rushing them into the ER, or they're calling the paramedics, and all of a sudden the kid is thinking, man, I thought I was eating M&Ms, and next thing I know, these doctors are putting hoses down my stomach and they're trying to make me throw up. And so it's very disturbing for them. One thing we must keep in mind is, was this an accidental poisoning or was it intentional? And consider, what are some of the leading causes of death in our school age and our teenagers? Is suicide. So did they intentionally ingest the Tylenol? Tylenol extra strength, that's one of the hot things that the kids think about. It's over the counter, readily available, not too hard to take, and they'll take a whole bottle of it. Some of the poison can be botanical, some of the plants that we have around our homes and in our homes. And remember, these children are not just at home, so if you childproof the home, it doesn't necessarily mean that wherever else they're going that it's childproof. The peak age that we're going to be seeing a poisoning is the 2 to 5-year-olds, and then the other end of the spectrum, looking at your teens. Males tend to be a little more curious at getting into those kind of things than females. But what contributes to the poisoning? We don't put the chemicals or medications away in a spot where they cannot get. We don't know what plants that are in your home are poisonous. And this is our house plants or our garden plants. And most of our accidental poisonings are occurring in the kitchen, in the bathroom, and in the garage, where we tend to store all of these harsh chemicals. If we know what the substance is, we put in a call to the Poison Control Center. It's a national body, and they have offices in a variety of regions, and the closest one we have, I believe, is in San Diego. It was at USC for a while. Anyway, we call that number and we let them know exactly what this child took. If they took pills and we have pills in our hand, but we don't have a bottle with a label, we can actually identify that in the PDR. You need to do a quick physical assessment. What is their behavior like? What is their level of consciousness when they get into the door in front of your eyes? And keep watching them to see if that is going to be going downhill. Take their vital signs. Temperature is not that important, but definitely the blood pressure, the heart rate, and the respiratory rate. Do you smell anything on their breath that you can recognize? Are you smelling bleach? Are you smelling a perfume that might be your favorite? These kids will drink anything. I know my own brother. He drank nail polish, and he drank it on more than one occasion. I guess it smelled good, so he decided to drink it. So he had to have his stomach washed out. Look at their skin. Is it warm and dry, or are they diaphoretic and pale? Are their pupils responsive? So remember when we put stuff up on the board and we're going down those body systems? Here's an instance where we do need to look at their pupils. Can they ambulate, and are they ambulating normally? Do they already have vomiting? Are they having diarrhea? Are they complaining of abdominal pain? Because many of the substances that they take, the body's trying to get rid of it by vomiting. But if they have that altered level of consciousness, we have to worry about aspiration. So evidence-based practice says that the best things to do in the incidence of a poisoning is either wash out the stomach, which is the gastric lavage, or use an activated charcoal to help it be absorbed and then excreted without it circulating, being absorbed into the bloodstream to circulate. The thing about the gastric lavage is it's only effective if it's within an hour of what this kid took. After that, it's not going to be effective. We can still give them syrup of Ipecac to make them vomit. That will work, okay? But the washing out effect isn't going to work. So it's better if we just let them vomit. So activated charcoal is exactly that. It's charcoal that we can actually ingest. It doesn't taste good. It's black. It looks like charcoal. And we're putting it in a bottle or in a cup, and we're asking them to drink it down. We can give them a single dose, or we can give multiple doses. And this is effective if it's within an hour of ingestion and up to 4 hours afterwards. So gastric secretions may be sent to the lab. It depends on what we actually know that they took in. We will be sending off levels. If a kid gobbled down, fistfuls of iron, we need to get those levels. If they took Tylenol, we're going to send off a Tylenol level. They may just do a tox screen. If we want to empty the stomach of whatever is in there, and Tylenol is one of those things that we can get rid of, we will give them syrup of Ipecac. So if they're greater than 1 year old, they will get 15 mLs, and that holds true until adolescence, and then we're going to double the dose. We will use this for Tylenol, which is the acetaminophen, aspirin, some toxic plants, and then iron-containing products, because iron can be very devastating to the body. So you're going to give this syrup of Ipecac, and then you are going to get a lot of bath blankets. You need to put on a gown yourself, and within 30 minutes, you need to have a wash basin. Forget the emesis basin. That is far too small, because they are going to have profound vomiting. The thing about using Ipecac is it only gets rid of about 30% of what they ingested. So they still have 70% circulating. Do not give this to anyone who has altered mental status. Tylenol is the most common drug that causes poisoning in children, and the toxic dose is 150 milligrams per kilo or greater in a child. You do not have to memorize that number, okay? But you do need to know what is the antidote for Tylenol. And we give Mucomyst. The real name is N-acetylcysteine, and it's given IV or PO. Most of the time we begin at IV and then we can transition to PO. It really depends on how much this kid took and what their Tylenol level is. You also should know what is the risk of someone taking too much Tylenol. One word of caution when you are using this Mucomist is it has a really nasty smell. And so when you are spiking the bottle for the first time, it will smell, and that's normal for it to smell. Try not to spill it on yourself and try not to spill it in the room because that odor is going to stay around. We will monitor Tylenol levels every 6 hours, and we're watching them till they trend down, and then they will discontinue the Mucomist. IV may transition them to PO, or they will discontinue it altogether. For aspirin, a severe toxicity is 300 to 500 milligrams per kilo. I'm sure when I was a child, I was probably at this level because I thought St. Joseph aspirin for children tasted really good, and I also had a really, really bad headache one day. So I just kept going in and helping myself, and man, my ears were ringing like crazy by the end of the night. And of course, I never told my parents, so I'm lucky. A chronic ingestion, so this would be the kids who, like me, was like, man, that St. Joseph's aspirin for kids is good, and I'm going to just keep taking a few every single day. So the level for toxicity actually goes down to 100 milligrams per kilo if they take it for more than 2 days. So we wash out their stomach. If we know within an hour, we will give them the syrup of Ipecac so that they vomit, and then we can give them charcoal to get the absorption of the rest of it. We have to give them some bicarb because aspirin is an acid and it causes a metabolic acidosis. They have an increased risk for developing pulmonary edema and fluid overload as well. And because of aspirin, it makes platelets not be sticky, but it also so it will cause bleeding, and so we will administer a dose of vitamin K just to minimize that risk of bleeding. Especially, we're giving them something to vomit, and it's so violent that they can end up having little hemorrhages in their eyes. They'll have petechiae in their face from the vomiting. Antipyretics and anticonvulsants might be needed depending on the level of the aspirin level, and if the acidosis is severe enough, these kids may go to dialysis. But primarily what you need to know is who gets washed out, who doesn't get washed out, and what kind of things do we do? Are there medications that we need to give to counteract the effect of these medications? So this ends the lecture on poisoning.